Alright, so yeah, with every program run, resolve us to complete the assignment and we completed the
So the only concern that I had with the assignments online, I understand what you're saying. It mentions on there that you do have an unlimited amount of times to get them all done, but it also only takes the last score, not your highest score.
yeah, the last score.
How are you, if you've taken it like 20 times, I mean, I guess unless you write it down, you have no idea what you made.
What you
Oh,
get?
you can check the grades on it.
Oh, you can't see it, okay, that's what I wanna know, like, how can you see, like, what?
Yeah, you can see the ones that we kept in the grade.
Okay, but like, if you miss by 90 and then 70 and you get 90.
And so the last one would be kept in the grade. Do you want this to move to be changed to make it for you as the highest rather than the last one?
Yes. Yes. Please. Yes.
I will change it for you. I thought this would be much more helpful to you to keep repeating it to score higher at the end.
Well, it was just that, like if you did it fairly well the first time and you did it again and you like accidentally did something wrong that you got right the first time, it made your score lower and then you have to do it again, like, you know.
Alright, so I will change it for you. I will make it the highest rather than the last one. Alright. So my idea why I did choose to make it the last attempt for you to keep repeating it over and over to get you used to it and finally get all of them correct. Alright, this was the idea behind it, but if you're not comfortable with it, I will change it. It doesn't matter. Alright? Questions again for the test. How do we study for the test? Again, this is a very common question on here. So we have again 2 parts of the exam coming up after tomorrow. We have the lecture part, which is going to be out of 100 points. And this is all going to be multiple choice questions. Those multiple choice questions going to be testing your understanding on the different topics that we covered in those 2 chapters, chapter 18 and 19. And a good source to practice for those multiple choice questions is going to be your Q banks. I told you last time that those assignments are meant for you to answer while we are covering the material. So during our class, right after class, you go and practice, have fun with the material using this courseware. All right, but this is not enough for you to study for the tests. All right, so the best source to study for this part of the test is going to be your Q bank. And the Q banks will be covering all the information that you need to know for the test. Information doesn't have to be the same exact question. Doesn't have to be the same exact question. As far as you understand, why did you choose this as a correct answer? You are good. All right. Historically, people who score high on the lecture parts of the exams, from what they get back to me was, so they tell me we didn't have to answer this 4 or 5 times in order to score high on the lecture parts. All right. So Q banks are very essential for this part. Very essential. For the lab part, again, the lab part is for another 100 points. And this is divided into 2 parts. We have the identification part and we have the blood pathway part. The identification part, I will be using the diagrams on blackboard. All right, so you need to be able to identify the cardiac diagrams, the different parts of the heart, the valves, the papillary muscles, the pili tendini. You need to identify the different parts of the heart from the different perspectives as what we've learned. You need to identify the different waves on an EKG. You need to identify the abnormal EKGs that you see on those diagrams. This is concerning the heart part of the identification. The blood vessels part, you're gonna have on blackboard those PowerPoints in which I did highlight only the blood vessels that we did cover in class, and those are the only vessels that you're gonna be tested on. So I will not be asking you the gonadal artery, for example. I will not be asking you the mandibular artery or the temporal artery. So those are not vessels that we did cover in class. We did only cover the main blood vessels. All right? It goes much more deeper to what we did discuss. So the blood vessels in your textbook are not all tested. Only the ones I did highlight for you on the PowerPoint slides. All right? My recommendation, in order for you to master the identification part, is to create your own slides. So if, for example, I have a slide for the heart like this, and those are stuff that I need to know. All right, so what will I do? I will create a PowerPoint. I have this diagram from the extracted, and it has unlabeled arrows on it. So I will ask, it says this is 1, this is 2, you're gonna number them for yourself. And on the next slide, I will leave the same diagram with the labels on it. This is how I study myself. I create my own flashcards on PowerPoint. So I have one slide which is unlabeled for me to test myself, and I have another one which is labeled for me to check my answer. So I press next, it will show me the diagram with the labels on it. Creating your own flashcards will help you to study for the material. Why you simply don't give us those flashcards? Because creating the flashcards will help you to study. You have pre-made thousands of flashcards pre-made on the internet, but they're all gonna be the same for you if you didn't create your own. You have pre-made flashcards, millions of text covering the heart and blood vessels. If you Google search them, you will find millions of them. All right? They won't be helpful unless you create your own. All right? The pathway, as what we've learned, I will not be giving you any organ to start from. I will start from a vessel, I will end in a vessel. So I will not be asking this patient to get an injection in the superficial part of his forearm, and you should be able to guess what vessel you're gonna start from, or you will end up to. There will be no guessing. I will be mentioning the name of the vessels that you're gonna start from, and the name of the vessels that you're gonna end up to. All right? This is concerning the pathways. The identification is gonna be 70 points, and the pathway is gonna be for 30 points. All right, so this part of this is gonna be around 74, or from 74 to 78 questions. This part of the test is going to be 64 to 66 questions. And each one of them is going to be out of 100 points. So it's going to be 1% of what you get scored.
How long do you get for each part of the exam?
So official time for each part is this one will be 45 minutes. And this one will be an hour and 15 minutes. So this will make a total of 2 hours.
Do you have a lecture after the?
We want, I normally go with that anytime.
Okay.
But if I could fit in any lecture, I will.
Can we start with the identification first, or do we have to do the lecture part first?
What I used to give you all the 3 different parts of the test to be taken at your own pace and then bring them forward. But I will be modifying this to try to get you the grades as early as possible. Alright, so I will be giving you the identification part first, then after an hour or 45 minutes, I will give you the lecture and the pathway parts.
What if you finish the identification in under an hour though? You start to like
Once
an
you
hour?
bring it for me, you take
Oh,
the next
okay.
part. You don't have to step out, you can take one after the other.
Okay.
Alright, but I will need to start grading this identification part as early as possible when you're still taking the other parts for you to not have a delay in the grade. For you to not have a delay in the grade submission, for you to know the grades as soon as possible.
Okay.
Alright, I will try my best to give you the grades at the end of the test. Alright? I will try my best. I will try. Alright? Not a problem.
You said no.
Alright? Questions concerning the test? So the lecture part is on a spectrum. This would be a written form. Alright? Questions? So some of you are requesting to use the laptops in class to take notes. So it's fine to use your devices. But if I did find that you are doing something else other than what we're doing, I would just ask you to leave the class. Alright? Is this good with everybody?
Yes.
Okay. Right, so moving on to the urinary system. The urinary system is going to be the system, organ system responsible for you to filter your blood. And as you know, any organ system is going to be full of multiple organs. What are the organs that could be sharing information of the urinary system? We're going to have the kidneys, ureters, urinary bladder, and urethra. So the organ responsible for the filtration of the blood is to be my kidney. It's going to be conducting the urine in the form of droplets, urine droplets, down to this muscular sac located in the pelvis. This is my urinary bladder. And because you are just allowing droplets ponds they get formed. So you're going to be accumulating them until you fill the urinary bladder with urine. And once you fill the urinary bladder with urine, you're going to be stretching the urinary bladder to the extent where it needs to respond by contracting. So you're going to be contracting the urinary bladder in response to the increased tension inside. And this accumulated urine will be released to the outside through another muscular tube. This is called the urethra. And we're going to see towards the end of this chapter the differences in the structure between the male and the female urethra. So again, the organs that would be responsible for you to filter the blood from the toxins, those are my kidneys. Kidneys will be forming the urine in the form of droplets that will travel down. And this will be the muscular tube conducting the urine down from the kidney to the urinary bladder. This will be my ureter. So again, we have a right kidney, a left kidney. And each one will be conducting the urine down through the ureter. So we have two muscular tubes conducting the urine down here to the muscular sac, which is my urinary bladder, that will then contract, releasing the urine to the outside through the ureter. You see on here, a quick reminder, what is the blood, where do I get the blood supply to my kidneys from? Can you remind me? What are the arteries? That would be renal arteries. The renal arteries are branches coming from the celiac trunk, right? Yes. 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 No? Yes. Yes. They are not. They are direct branches from abdominal aorta. They are not branches from the celiac trunk. Can you remind me what are the three branches from the celiac trunk? What are the three branches coming from the celiac trunk? One goes to the liver, this is mine. Hepatic, one goes to the spleen, this is and one that goes to the stomach, this is mine. Gastric artery. We got inferior mesenteric, superior mesenteric, and renal arteries. Those are direct branches from the abdominal aorta. They are not coming from the celiac trunk. This is one of the most common wrong answers I will see tomorrow on the test. Renal arteries are not coming from the celiac trunk. Renal arteries are direct branches from the abdominal aorta. So you're going to deliver the blood going to be filtered, and then you're going to get this blood back to your heart through what vessels on here? What veins will be draining your kidneys? Renal veins. The renal veins draining to the hepatic portal vein to the liver?
No.
No, they will drain directly in my
Abdominal.
inferior vena cava, which will get the blood up to my right kidney. So you see on here, renal arteries are direct branches from the abdominal aorta. Renal veins will directly drain into the inferior vena cava. Alright, so what's going to be the renal functions? First is going to be to remove the toxins, metabolic waste, excess ions from the bloodstream. So whenever I get exposed to excess ions, I have too much sodium. Who will get rid of this sodium? My kidneys. If I did get exposed to large amounts of calcium, who will get rid of this excess calcium? My kidneys. So any disturbance in the ion concentration, who protects me from this? Is going to be my kidneys. Those excess ions will be removed in the urine through the kidney. Alright? So if I did eat large amounts of water, what's going to happen to my blood volume? What do you think? Will I have an increase in my blood volume? If I drink lots of water, what's going to happen to my blood volume? Increase? Decrease? Nothing is going to happen to my blood volume. So if I drink lots of water, so if I have a liter of water. I did drink 1 liter of water. Or fluid, whatever fluid. What's going to happen to your blood volume? The amount of blood in your blood vessels. Increases, right?
Yes.
Increases. Remains the same. Decreases. So what do you think? If I drink 10 gallons of water, what's going to happen to my blood volume?
That's not necessarily true.
Nothing. All this excess water above your normal blood volume going to be released out in the urine. So it will increase to become normal if it was low. So you increase to normal, but if you already have a normal blood volume and you didn't drink lots of water, what's going to happen above? Will you increase the blood volume above normal? No. All this excess water is going to be released out in the urine. So the kidneys will be filtering, and this will protect your blood volume. If you are accumulating acids, if you are accumulating bases, all this might disturb your blood pH, and as a result, what's going to happen? Nothing much will happen because my kidneys are functioning normally, and I will be getting rid of those acids, those bases out in the urine. So kidney is also going to be regulating your blood pH and the chemical composition of your blood. So again, my kidneys will be regulating the blood volume, chemical composition, and blood pH. They will be responsible to remove the metabolic waste and the excess ions. Other functions for my kidney is going to be my gluconeogenesis, and this will be taking place during prolonged fasting. What's gluconeogenesis? Creation, genesis of new sugar. So if I am fasting, what will increase my blood sugar level? What do you think? If I'm fasting, will I have a normal blood sugar level, or my blood sugar will drop below normal?
It's going to drop.
All right, if I'm fasting, what's going to happen to my blood sugar level? It goes down to normal. But will it drop below normal? So will my brain be able to function having a low blood sugar level? No. So you need to maintain it at a normal level.
Kidneys increasing.
So how do I increase the blood sugar level? You're going to be converting first source. Here is going to be your glycogen inside the liver. If you remember, the liver stores glucose in the form of glycogen. And once you have a decrease in the blood sugar level, what's going to happen? Your pancreas will be releasing a hormone. Can you remind me of this hormone? Insulin? Is it insulin? What do you think? Insulin will do what to your blood sugar level? It decreases. It decreases. So insulin is supposed to decrease. Do you want insulin to be released if you are starving? So what do you need to release other than insulin that will increase your blood sugar level rather than decrease? What was the other hormone that you did release from the pancreas other than insulin? This was my Glucagon will go to the liver cells and will raise the glycogen, releasing this glycogen in the form of glucose to the outside. Also, it will stimulate the fat cells to release their own triglycerides. And for this fat and the proteins that will be resulting from the breakdown of the muscles, we're going to be using those fats and proteins to transform them into sugar. And we call this chemical reaction in which you are using fats and proteins to transform them into sugars. This is the creation of a new glucose molecule. This is what we call gluconeogenesis. Another site where gluconeogenesis will be taking place is going to be your kidneys. So what we've learned back in chapter 16 in the endocrine chapter, that gluconeogenesis will be taking place in the liver cells. Another place for gluconeogenesis is going to be your kidneys. What is again gluconeogenesis? This is the formation of new glucose from either fat or proteins, from either the glycerol or the amino acids. All right. So again, a function of the kidney is to release glucose from a non-carbohydrate source. Why do we have another source for gluconeogenesis to take place? Because gluconeogenesis in the kidney is not actually responding to the glucagon of the pancreas. It's responding to the adrenaline coming from the adrenal gland. If you look on here, above the kidney we have an adrenal gland. And one of the hormones that you release from the adrenal gland is going to be the epinephrine and norepinephrine. So in case of stress, in case if I am activating the sympathetic nervous system, in case of fight or flight, you're going to be releasing lots of adrenaline, epinephrine and norepinephrine in the bloodstream, and you want to increase the amount of glucose in your blood, because in a fight or flight situation, you need to get more energy to your muscles. So where will I be affecting here to get more glucose? One of the places is going to be your kidneys, where they will be responsible for the production of glucose from non-carbohydrate source. You're going to be transporting fats and proteins into glucose, gluconeogenesis. Another functions for the kidneys will be endocrine functions, and I'm releasing two kinds of hormones. The hormones that will be responsible for the production of the red blood cells, and this is called my erythropoietin. Erythropoietin is going to be stimulating the red bone marrow located in the flat bones of your skeleton to divide and produce red blood cells. If you remember what erythro means red. So erythropoietin, I am the hormone, I am the protein that enhances the production of what cells? Red blood cells. So erythropoietin here is a hormone that enhances the production of the RBCs. Another hormone that we're going to see on here released from the kidney, and this will be one of the main topics that we're going to be covering in these two chapters. This would be the renin. And the renin is going to be responsible for increasing the blood pressure. Can you remind me of the three hormones that we did mention last time that would be increasing your blood pressure? Angiotensin 2, epinephrine, and norepinephrine. And the third one was the one that prevents the loss of water in urine. This was mine. Diuretic hormone, ADH. Those are the three hormones that we've mentioned that will be increasing your blood pressure. So renin actually going to be activating the angiotensin 2. It will transform it from its inactive form to its active form, which is angiotensin 2, for it to constrict the vessels, as we're going to learn later on in this chapter. So renin function is to do what to my blood pressure? Increase my blood pressure. So again, what are the key functions of the kidney so far? I am removing waste, I am removing toxins, I am regulating the blood chemistry, composition, I am regulating the blood volume, I am regulating the blood pH, I am responsible for the gluconeogenesis in case of stress, production of glucose from non-carbohydrate source. I am also going to be responsible for the production of two hormones. One is essential for the production of red blood cells, erythropoietin, and the other one is going to be increasing my blood pressure. This will be my renin, which is going to be converting, as we're going to learn, angiotensinogen, which is the inactive form of the hormone, into its active form, angiotensin 2. Also, it's going to be responsible for the activation of vitamin D, and activation of vitamin D is essential for you to be able to absorb the calcium. if you remember, why do I need to have active vitamin D? Why do we have to have activated vitamin D? Remember, in the intestines, how would I be able to absorb the calcium? Calcium needs vitamin D for it to be absorbed. If you go today to a grocery store and check which section would have a lot of vitamin D advertisement. There. Why? Because people will go to get milk, even non-dairy milk, for them to get enough calcium to have strong bones, right? Everybody will go to buy milk for their children to have strong bones. But if I did drink lots of milk, lots of calcium passes in my intestines without having vitamin D, would I be able to absorb this calcium I'm getting from outside to my blood? No. So vitamin D is essential for you to be able to absorb the calcium that you're ingesting. If I don't have activated vitamin D, there is no point for me to get calcium. Alright, so and the activation of vitamin D is taking place on two steps. One step is taking place in your skin, and the other step is going to be taking place in your kidney. For this activated vitamin D to go to your intestines and allow the absorption of the calcium. We have two hydroxylases enzymes, one located in the skin and the other one will be located in the kidney for you to be able to get the active form of vitamin D. And this active form of vitamin D is what allows you to absorb the calcium. So again, one of the functions of the kidney here is to activate vitamin D needed for you to absorb calcium. Questions?
Is that why you get, some people say you get, to be in the sun, it activates your vitamin D?
Yeah, so if you get enough sun exposure, this will help the first step of the activation of vitamin D. So vitamin D is actually released from the skin in the form of cholecalciferol, and then you're going to need to break down a hydroxyl group from it by a hydroxylase enzyme in the skin, and this enzyme will be activated by sun exposure. And then you're going to be doing another removal of a hydroxyl group in the kidney for you to have this active form, and the active form is 127 dihydroxycholecalciferol. This is the active form of vitamin D. This is the ones that you're going to be using in your intestines to absorb the calcium. So you're going to need to remove two hydroxyl groups from the initial vitamin D structure. One of them is taking place in the skin, the other one is taking place in the kidney. So in order for me to do the step, the activation step in my skin, I need to get exposed to the sunlight. That's why people who live in the north will need to take supplements of vitamin D because they don't have enough sun exposure. Alright, so if we're looking on here, the kidneys, ureters, and the urinary system is located retroperitoneal. What I mean by retroperitoneal, they are located behind the peritoneal cavity. So all the abdominal organs are located in this cavity inside the peritoneum, but retroperitoneal, behind the peritoneal cavity, you're going to keep your kidneys away. So why do you think? Why do you think you're going to keep kidneys away? Why do you think I'm treating my kidneys in a special way? I'm giving them separate blood supply. I'm giving them separate venous drainage. I keep them away from the other abdominal organs. All of the other abdominal organs are kept together in a peritoneal cavity, but my kidneys are kind of special. They are behind, away from the other organs. To keep them protected. To keep them protected, because you see here, any person who will get problem filtering his blood, for how long can I survive? If I have a renal failure, I cannot. I need to do a dialysis 2-3 times a week. So try to imagine that you did eat a large pizza, so you did increase the intraperitoneal pressure, and this will kink the ureters, blocking the ureters on here because you did eat a large meal, or you have constipation, for example. Increase intra-abdominal pressure, intraperitoneal pressure. This might compress the ureters if the ureters were passing inside peritoneal cavity. So would you like to have a renal failure because you have constipation? No. All right, so kidneys are kind of protected, being kept outside of the peritoneal cavity. All right, so again, what do we call this? Where are the kidneys located? They are located retroperitoneal. Retroperitoneal, behind, as you see on here, my peritoneal cavity. So if we look on here, we can see that kidneys are receiving their own blood supply directly from the abdominal aorta. They will get their separate venous drainage directly in the inferior vena cava, runs through the renal veins. If we have a transverse or recessional section of the kidney, how does it look like inside? When we look at the transverse, the sagittal section of the kidney. The kidney will be divided into an outer layer and an inner layer. The outer layer of the kidney is what we're going to call the renal cortex. The inner layer of the kidneys, this is what we're going to call the renal, can you guess the name? Medulla. Medulla. So again, the kidney will be divided into an outer layer, outermost layer of the kidneys. This is my renal cortex. Inner layer is going to be my renal medulla. And if we look at the renal medulla, we're going to find that I have triangular shaped structures if I look at the section, but if I follow each one of those triangles, I will find that it's a pyramid, not a triangle. So we're going to call them the renal pyramids. Renal pyramids. Those triangular shaped structures that would be for filling my medulla, those are called my renal pyramids. Renal pyramids. Those are my renal pyramids. This is where you're going to be conducting the final form of urine through my renal pyramids. Here I will be conducting the final shape of the urine into smaller tubes inside that are passing inside of my renal pyramids to be conducted into ducts here that will come out from the tip of the pyramid. This is called my renal papilla. So again, the tip of the pyramid here, this is my renal papilla. So all the renal papillae here will be conducting the urine that have been collected by each of the renal pyramids to small ducts. Those small ducts are going to be called my minor calyces. So again, each renal papilla, each tip of the pyramid will be conducting the urine into a small duct. This is called my minor calyx. Multiple minor calyces will be fusing together, forming a larger ducts, like those ones. Those are called my major calyces. Multiple major calyces will fuse together, will form this funnel shaped this funnel-shaped tube that will be collecting the urine to the outside of the kidney. This is called my renal pelvis. And the renal pelvis, as you see on here, it will be conducting the urine to the outside of the kidney, passing through this vascular tube. This is my urine. And then after you get to the ureter, what's going to happen to this urine? It's going to be collected down in the urinary bladder until you fill the urinary bladder for it to contract and release the urine to the outside in my urethra. So again, where will you be collecting the urine? The urine is going to be collected through those ducts, passing in what's the structure? What do we call this triangular shaped structure in the medulla? Those are my renal pyramids. Renal pyramids will be conducting the urine to the tip of the pyramid. What do we call the tip of the pyramid? This is my
Renal papilla.
renal papilla. The renal papillae will be conducting the urine to small ducts. What do we call the small ducts?
Minor
Here,
calyx.
my minor calyces. Multiple minor calyces will fuse together to form a large duct. What do we call the large ducts on here?
Major calyx.
Major calyces. Multiple major calyces will form together this funnel-shaped tube. This is my
Renal
pelvis. And the renal pelvis is going to be conducting the urine in the form of droplets down through this muscular tube. This is my
Ureter.
ureter. So again, structure of the kidney. This is what we're going to be. This is what we're going to be discussing when we do the kidney dissection next class. All right, next class after the dissection.
Yeah, I was gonna say dang.
So again, we have an outermost layer of the kidney. This is my renal cortex. The remaining part is going to be my renal medulla. Renal medulla is going to be divided into
Renal pyramids.
renal pyramids. Each renal pyramid has a tip of the pyramid. This is my renal papilla, or the papilla of the pyramid. It's going to be conducting the urine in small ducts. What do we call the small duct? That would be receiving the urine out of the tip of the pyramid. Minor calyx. Multiple minor calyces. Those will fuse together and will form a
Major
calyx. Multiple major calyces will fuse together and will form this funnel-shaped tube. This is my
Ureter.
renal pelvis. Renal pelvis conducts the urine down in the form of droplets through this muscular tube that will carry the urine down to the urinary bladder. This is my
Ureter.
All right. Questions concerning the structure of the kidney? Questions concerning the structure of the kidney? If we're looking on here in the renal cortex, we're going to see that the renal cortex is granulated. I have tiny little granules inside, located in the outermost layer out there. Those tiny little granules, we're going to see what they are formed of in a second. And form of granulated tissue, have tiny granules inside the renal cortex. Questions? All right, let us have a break for 10. We come back, discuss the nephron, which is the structural and functional unit of the kidney. Don't want to start and have a break after in the middle of the nephron. All right, I want to complete the nephron in one second. So looking under the microscope of the structure of the kidney, what we can see that the kidney is formed by microscopic structures. Those are called nephrons. I form the urine is so simple. It's like an exchange between the kidney tubules and the blood vessels. So I have fluid in my blood vessel, which is my blood, and in my kidney tubules I have what we're going to call the filtrate. The modification of this filtrate is what will result in the formation of the urine that will be released out of the kidney and then to the outside of the body. This is the structure of the kidney tubules that will share in the formation of the nephron. Each kidney has 1 million nephrons. So you get a total of 70, you get a total of 2 million nephrons into kidneys. 15% of those nephrons gonna be juxtamedullary nephrons. Juxta means close. Juxtamedullary, so they are close, they are located in the cortex, but they are close to the medulla. Juxtamedullary nephrons. And those juxtamedullary nephrons, those will have long tubules that are passing down into the medulla. 85% of the nephrons that you do have in your kidneys are cortical nephrons. So you see on here, most of the tubules that will be forming my cortical nephrons are going to be located in what part of the kidney? In my cortex. So again, how many nephrons I do have in my kidney? 1 million nephrons. We have how many types of nephrons? 2 types. Either they are located in the cortex, close to the medulla, so we're going to call them juxtamedullary, close to the medulla, or they are located mainly in my cortex. So we're going to call them my cortical nephrons. So again, 2 types. Both are located in the cortex. Both are located in the cortex. One of them is close to the medulla. It has long loops that will travel down in the medulla. Those are called juxtamedullary nephrons. And we have another type, which is going to be mainly located in the cortex of the kidney. This is my cortical nephron. So again, how many types? 2 types. What is the most common type? My cortical nephrons are representing about 85% of the number of nephrons I do have. So let's check down here how you're going to be forming the urine. First, the structure of the nephron. I am full of tubules like the ones that you see on here. And surrounding those tubules, you're going to have blood vessels, capillaries. Can you remind me, what are the 3 types of capillaries that we do have according to the structure of the capillary? We have continuous capillaries, we have fenestrated, and we have sinusoidal capillaries, right? Sinusoids. Do you remember what is the type of capillaries that we mentioned that we have in the kidney?
Fenestrated.
Fenestrated, continuous, or sinusoidal? Fenestrated capillaries. Fenestrated capillaries. So where do we have the capillaries? Actually, around every single part of my kidney tubules. So I have a capillary inside this cup-shaped tube. I have sets of capillaries that will be surrounding those tubules. And I have another set of capillaries. This time they will be surrounding the long loop I have coming down from my nephron. So let's first start by identifying the different parts of the kidney tubules that we have. Well, we start first with this cup-shaped tubule. This is called my Bowman's capsule. And the Bowman's capsule, another name that we use for it is the glomerular capsule. is this cup-shaped tubule that we're gonna have as a start point, as a starting point of my nephron. Comes after a set of tubules. Those are the proximal convoluted tubules. Proximal convoluted tubules. Then we're gonna have this loop on here. This is called the loop of Henle. Loop of Henle. Loop of Henle. So you start with again boneless capsule, then proximal convoluted tubules, then the loop of Henle. Then I would have another set of convoluted tubules. By the way, so can you guess the name of here? Distal convoluted tubules. And from the distal convoluted tubules, you're going to be getting one of the last forms of the fifth grade to be collected. So I'm going to have a tubule here that will be collecting the urine from many nephrons and will conduct this urine down through the pyramids of the middle. Those tubules that are collecting the urine, we're going to call them my collecting tubules or ducts. Collecting ducts. So again, what are the different tubules that we have forming the nephron? We have this cup-shaped tube. This is called my bonus capsule or glomerular capsule. Then we have the proximal convoluted tubules. What's that?
Your screen's going haywire.
All right, so proximal convoluted tubules. What comes after?
Loop of Henle.
Loop of Henle. Then we're gonna have distal convoluted tubules. Then you're gonna be collecting the urine through your collecting ducts. And the collecting ducts are the ducts that will be passing through the kidney tubules. You see those lines on here? Those are actually the collecting ducts that did collect the urine to be released at the tip of the renal pyramid, at the renal papilla, for it to pass to the minor calyx, to move to the major calyx, and then to the renal pelvis to be released down through the ureter to reach the urinary bladder, urethra to the outside. So where is the urine going to be formed? In here, in those 1 million nephrons. It's a matter of exchange that's going to be taking place between the blood and the kidney tubules. So let's check here what are the different forms of capillaries that will be sharing in the formation of the structure of the nephron. The first set of capillaries that we can see on here, those are the capillaries located inside of the bonus capsule. Those are called my glomerular capillaries or my glomerulus. So the first tuft of capillaries that we're looking at, this is called my glomerulus. Next tuft of capillaries that I can see on here, those are the capillaries that will be surrounding my proximal and distal convoluted tubules, and those are called my, can you guess the name? If I am the capillaries surrounding the tubules, what do you think? I am
Peritubular capillary.
surrounding, so this would be peri, and around what? I'm around the tubule, so I'm called peritubular capillary. So the second tuft of capillaries that you can see up here, those are the peritubular capillaries. Another set of capillaries that I can see, those are the capillaries that surrounding my long loop of Henle. So they are forming a straight vessel. So I will call this vessel surrounding the loop of Henle. Straight is, so why the rectangle is called rectangle? Why do you think? Why a rectangle is called rectangle? Yeah, it has straight angles. Right? Straight is recta. So if I have part of the coolant that travels down straight, it's called rectum. All right. So if I have a vessel that goes down straight, I will call it my vessel, vasa, and straight is rectum. So you're going to have the third type of vessels that will be sharing the formation of my nephron. This would be my vasa rectum. So again, what are the three different vessels that will share in the formation of your nephron? Those are my glomerulus, my peritubular capillaris, and vasa rectum. Again, vasa is vessel, and recta is straight. So it travels straight vessel. So let's check on here the different characteristics of each one of the kidney tubules as well as the capillaries. We didn't mention yet how to form the urine. We are just getting to know the characteristic of each one of those tubules and each one of those vessels. So the first stock of vessels here, those would be the glomerulus, and the glomerulus needs to have high pressure. How do I create a high pressure within my vessels on here, within my capillaries of the Bowman's capsule? I have two arteries. One that brings the blood to my glomerulus. This is called my afferent arteriole. And one that drains the glomerulus to the outside. This is my efferent arteriole. How do I create a high pressure in between? What do you think? What do you think? What did create a high pressure in between the afferent arteriole and the efferent arteriole in the glomerulus? First factor that will increase the blood pressure in here is the difference between the diameter of the afferent arteriole and the efferent arteriole. So if I'm telling you, you have a container, and you're getting 10 liters of water to this container, and you're draining to the outside only 5 liters. 5 liters are drained to the outside. What's going to happen inside this container?
It's going to fill up eventually.
What's going to happen to the pressure? Will I have a high or a low pressure? If the amount I'm getting in is much higher than the amount I'm moving out, I'm creating high pressure. And this high pressure, what's gonna result in? Why do I need to have a high pressure on here? Because this is the first step. This will be responsible for the first step of the urine formation. This would be responsible for the filtration. So I need to have a high pressure within my glomerulus to push the fluids from my glomerulus to my Bowman's capsule. So if you see on here, in order for me to start forming the urine, I need to create a fluid within my kidney tubules.
which will start with my Bowman's capsule. So I need to get the fluid to travel from my blood vessel. This is my blood, this is my plasma. And this fluid will need to travel from my vessels in here, which is going to be the glomerulus, to the inside of my kidney tubule, which is going to be my Bowman's capsule. So the fluid needs to travel from inside the glomerulus, from my blood, to my Bowman's capsule to form what we call the filtrate. So if you are willing to push water, fluids out from the glomerulus to the Bowman's capsule, do you think you will need high or low pressure? So if I have another exit on here, would I be able to move the fluid into this exit if I am allowing 10 liters of fluid to be drained on the other side?
No.
No. Why? Because simply pressure will not build up and the fluid will not try to find another exit to travel through. So, but if I'm creating a difference in diameter between the vessels that brings me the blood and the vessels that drains the blood out, this what creates the difference in pressure, and this accumulated pressure is what's going to drive the water to flow in another direction. And what is the other direction available on here? It is for the fluid to travel from my capillaries of the glomerulus into my Bowman's capsule. And this is the first step of the urine formation. This is my filtration. So again, why do I need to have high pressure within my glomerular capillaries? To allow filtration to take place. And how did you get this high pressure within the glomerulus? How did I get high pressure within those capillaries? First factor is the difference between the diameter of the afferent arteriole and the efferent arteriole. Which one is going to be larger, the ones that brings blood or the ones that drains blood out? That brings blood. So the amount that you're getting is much higher than what you're releasing. So what's going to happen in between to the pressure? Will it increase?
Increase.
Yes, it will increase. And having this high pressure, try to imagine, this is what we're going to be using over and over. So remember, this part is going to be my blood. This is my vessel. And this tube here is going to be my kidney tubule. So if I want to push fluids from my blood into my kidney tubule, I need to have a high pressure. And how do I create a high pressure again within my glomerulus? I am getting more than what I am
putting out.
draining. Arteriole, afferent arteriole brings much more blood. I have a larger diameter, so I'm getting more blood than what I am releasing out through the efferent arteriole. I have a difference in the two diameters. And this creates a high pressure which will allow you to push the fluid from your blood into Bowman's capsule. This is the first step of the urine formation, which is filtration. But as we're going to learn, we are having huge amount of filtrates that we're going to be producing. You are producing 125 milliliters of filtrate per minute. You don't have to go to this point. So we are producing how many liters of fluid per day? What do you think? So can you calculate this?
That's a lot of money.
So 120
That's
120 milliliters per minute.
60 times
So in 1 hour, you multiply by 60. And how many hours do you have per day?
24.
24. And this gives you the amount in milliliters. So you're going to divide it in 1,000 to get the amount in liters. So can you do this on a calculator?
20 times 60 times 24. So it's about 175 liters. You release 175 liters of urine per day. What do you think? You release 175 liters of urine per day.
I'm gonna call BS on that. Yeah, that's nuts.
You release 175 liters of urine per day?
No way.
So how come? If I'm getting rid of 175, if I'm filtering here, the amount of fluids that passes from my blood to my
Yeah,
bolus
think about
capsule
a 2 liter
of those
soda.
1 million nephrons I have per kidney is going to be 175 liters per day. I don't release this amount in the urine. So, how do you explain this? Simply because you're going to be getting most of it back. So, what do you think? Do I need? If I'm telling you, you are releasing this huge amounts of fluid passing from the blood vessel in the glomerulus to the bolus capsule. If I'm telling you that later on in the proximal convoluted tubules, you will need to reabsorb to get most of this fluid back. Almost 99% of this fluid will need to be recollected back into your blood from the filtrate. Because simply, you're not producing 175 liters per day of urine. You're going to get more than 99% of this amount back by reabsorption. And the reabsorption will be taking place here between the proximal convoluted tubules, distal convoluted tubules, and the blood vessels that will be surrounding them. Those are going to be my peritubular capillaries. So what do you expect? Do you need to have high or low pressure in your peritubular capillaries? What do you think?
Low.
So, if this is my blood, again, here is my blood vessel, and this would be the kidney tubule. In this case, we're not dealing with glomerulus and bolus capsule, we are dealing with peritubular capillary. This is my peritubular capillary, and this is my proximal and distal convoluted tubules. Alright, so I want the fluid to move from where to where? From the kidney tubules to my blood, or from the blood to the kidney tubules? If I want to reabsorb, to get fluid back to my blood, I want the fluid to move from where to where?
Blood to kidney tubules.
So, let me number it here. So, from 1 to 2 or from 2 to 1?
1 to 2.
1 to 2 or 2 to 1. If you want to get the water back?
1 to 2.
1 to 2. So, what do you think? Do you need to have a high pressure in the peritubular capillaries or a low pressure? Low pressure. I need to create a suction pressure. To move the water back from my kidney tubules to my peritubular capillaries, I need to have a low pressure, a suction pressure, to get this fluid back. I need 99% of the fluid I did just filter to move back to my blood. So how do I create this low pressure within my peritubular capillaries? How do I get this low pressure within my peritubular capillaries? What do you think? What's the contributing factor in here? Where do I get the fluid from? Where do I get my blood from? From what vessel? My efferent artery. You see on here, which did have a much smaller diameter. So I have very small amounts of blood that will be probably in the peritubular capillaries, because the source of the blood in the peritubular capillaries is going to be my efferent arteriole, which will have a much smaller diameter. So let's do numbers on here.
Smaller, but it'll move faster.
So if I was bringing 5 liters to the inside of this glomerulus, and I'm draining out 2 liters in the efferent, so the difference is going to be 3 liters. Where would they go? If I'm getting 5, draining 2, where is the rest? Filtered.
It's gonna move from my glomerulus to my bolus capsule. So now I have 3 liters in here. But I want to get most of this fluid back. So what will I need to do? I need to create a low pressure. So which side has a low pressure now? Your blood side. Which one side has low pressure, 2 or 3? 2. So one of the factors that will create this low pressure within my peritubular capillaries is that the source of the blood is going to be my efferent arteriole, which has actually a small diameter. And if I have a small diameter, this means I'm getting large amounts or small amounts of blood? Small amounts of blood. And having small amounts of blood, will this create a high or low pressure? If I have this amount of blood, this amount of blood, which one will have a higher pressure? Small amount or large amount? Large amount will have high pressure. Small amounts will have low pressure. So you see on here, if I have low blood volume into my peritubular capillaries, this tells me I am having a low pressure, which will allow me to get the fluids back from my kidney tubules into my blood. Most of the reabsorption going to be taking place in here, moving the fluids back from the kidney tubules to the blood. Alright, why did you need absorption, reabsorption to take place? Why did I need reabsorption to take place? Are you releasing this amount as urine? No. Most of it is going to be reabsorbed. And this will be the second step of the urine formation. So you did filter, you did reabsorb, you did collect back whatever you need. And the third step is going to be the secretion. You're going to be releasing whatever you didn't release by filtration. All right? Moving on to the blood vessels that's going to be surrounding my loop of Henle. This straight vessel, this is called my vasa prep. Who did have long loops of Henle? What type of nephrons? Can you see on here? Which type of nephrons has long loops of Henle? The ones which are located next to the medulla, juxtamedullary nephrons, or the ones that will be mainly located in your cortex? What do you think? Which one has long loops of Henle? Juxtamedullary nephrons.
Yeah.
And those juxtamedullary nephrons are going to be surrounding their loops of Henle or long loops of Henle by those straight vessels. That's right. What do you think? If I'm telling you I have a long loop of Henle, long kidney tubule, and I'm surrounding this kidney tubule with blood vessels, what do you think I want to do to allow more filtration or more reabsorption to take place? What do you think? Would you like to make any more filtration, more than this? Yes or no? No, you don't need. You are producing large amounts of filtrate. So what do you think I will need to do? I need to get more reabsorption. So in case, if I got lost in the desert, I have nothing to drink. So would you like me to release large amounts of water out in the urine?
No.
Or you need me to form concentrated urine? So if you didn't drink for a day or two, what's going to happen to the color of the urine?
It gets darker.
It gets darker. Why would it get darker? Because it's going to be more concentrated. So what did I do in order to make it more concentrated? I did reabsorb the water back to maintain my blood volume. You don't want to lose water out to not have a shock, because if you did drop your blood volume, can you remind me what's going to develop? You're going to develop hypovolemic shock. So I don't want to develop hypovolemic shock, so I will be retaining this water. I will reabsorb this water. So what do you think is going to be the function of a nephron, the type of nephrons, which will have long loops of Henle and surrounding those long loops of Henle with blood vessels to do what? To get more reabsorption, to get more water back into the bloodstream.
So what's going to be the function? If I did ask you, what is the function of those 15% of the nephrons that have long loops of Henle, juxtamedullary nephrons, what do you think is going to be the function of those nephrons? Reabsorption and a formation of concentrated urine. If I did ask you, why do I have long loops of Henle? What's the function of those long loops of Henle? It's going to be reabsorption of water, formation of concentrated urine. If I did ask you, what's going to be the function of the vessels surrounding the long loops of Henle, vasa recta? What's going to be your answer? Reabsorption of water, formation of concentrated urine. So you see on here, I have juxtamedullary nephrons with long loops of Henle and vasa recta, all this to form concentrated urine. All right?
So the vasa recta and the loops of Henle only come into play when you need to keep more water inside you?
Yes.
So when they're not
that
needed.
will, yeah. So
Okay.
most probably I will not rely on them
Unless you need it.
unless I need to reabsorb more water.
Okay.
All right. So you see on here, it's going to be the function on here. What's going to be the function of the vasa recta? Those long vessels that travel parallel to the long loops of Henle. This will be to form concentrated urine and getting more water back. All right. So the functional unit of the kidney, what do you think? Ureter, renal pelvis, nephron, minor caps. The functional unit, what do we call it? Nephron. So let's start with the first step of urine formation. This will be my filtration. And in order to understand the filtration, we need first to study the membrane that's going to be allowing the filtration through. So, can you remind me again, what is the type of capillaries that I have in my kidneys? Those are my fenestrated capillaries. Now remember, any capillary is going to be full of how many cell layers? One row of cells, which are flat cells, simple squares epithelium. And those epithelial cells are going to be fenestrated in the case of fenestrated capillaries. So you're going to have pores in the cells of those capillaries. So those are my endothelial cells of the capillary. Below this endothelial cells, we're going to have the gel-like basement membrane. Gel-like substance to which the cells are going to be attached. And you're going to have the cells forming your Bowman's capsule. So those are cells with feet. Those are called my podocytes. So again, 3 layers. This will form my filtration membrane. First cell layer is going to be my fenestrated endothelium. Fenestrated endothelium. Next is going to be my gel-like basement membrane. And the third layer is going to be my podocytes of the Bowman's capsule. So if we look on here, what can we see on the side? So we are magnifying the junction here between the capillary and the Bowman's capsule. See here, I'm magnifying what's inside the square. This is my filtration membrane. So again, what are the 3 layers of the filtration membrane? Fenestrated endothelium, gel-like basement membrane, and the podocytes of the Bowman's capsule. All right. So what's inside your blood? So this side I have my blood. This is my blood here.
Okay.
And here I have my, what is the name of the fluid that we're gonna have in here? In the woman's capsule? What do we call the fluid in here? This is called my filtrate. Alright, so again, what is the fluid inside the vessels? This is my blood. And what is the name of the fluid that we have inside the kidney tubules? Is my filtrate. Alright, is this clear?
Yes.
Again, what is the fluid in your blood vessels? Blood. And what is the name of the fluid inside your kidney tubules?
Filtrate.
So how the blood will form the filtrate?
Okay.
So first thing, you did create a high pressure. So this high pressure pushes the fluids in this direction. I am pushing the fluids to move from my capillaries to my Bowman's capsule. I am pushing the fluids out. But who will not be able to get filtered? Do you remember the fenestrated endothelium, the fenestrated capillaries, are cells able to allow cells to travel?
No.
Yes or no?
No.
What kind of capillaries did we mention that will allow the cells to move between the tissue sinusoidal? So the fenestrated endothelial lining of the capillaries, will that be able to allow cells to travel?
No.
So normally I don't see blood cells in my urine. Why? Because the blood cells will not be filtered on here through the filtration membrane. Why you did not allow the blood cells to get filtered? Because those fenestrated capillaries are not designed to allow cells to travel. The pores of the fenestrated capillaries are so tiny for a cell to travel through. Unlike the sinusoids, which are going to be present in the bone marrow, in the liver, and my spleen. Those will allow cells to travel, yes. But here, we don't allow cells to travel. We don't see blood cells in the urine. But what else can travel? Everything else can travel, with few exceptions. Any plasma protein. Plasma proteins are negatively charged. Also, the basement membrane, this gel-like basement membrane, is also negatively charged. So what's going to happen if you do have two negative charges? Would I have repulsion or attraction between the two? Repulsion. So if I try to travel through the filtration membrane, what's going to happen to me as a plasma protein? Whenever I get closer, I will be pushed back. Alright, so what is the first thing that you're going to be preventing from being filtered into the Bowman's capsule? Here, this would be my blood cells. Why the blood cells will not be able to travel to get filtered? Because simply they are so big to pass through the fenestrations. Plasma proteins. Why the plasma proteins will not be filtered out in the urine? Because they are negatively charged. And if they are negatively charged, like what in the filtration membrane is negatively charged?
The gel-like basement
membrane is also negatively charged. So they will not, I will have repulsion between my plasma proteins and my gel-like basement membrane. A third thing is going to be the macromolecules. Macromolecules like what? Like hormones, for example. Large hormones. Macro is
big.
The macromolecules, like for example, the hormones that you are producing, the enzymes, stuff like this. Would you like to release them out in the urine, or you want to keep them in the circulation
Keep them.
to carry on their functions?
Keep them.
You want to keep them in the circulation to carry on their functions. You don't want to get rid of them in the urine. So the macromolecules will not be filtered out because they have a large size
compared to those filtration slits between the feet of my podocytes. So you see on here, between the feet of the podocytes, you have those filtration slits. Those are the spaces available for the substances to travel through. If I am too big to travel between those feet of the podocytes, those macromolecules will be kept and they will fail to get filtered out in my Bowman's capsule. So again, what are the three layers of the filtration membrane? Fenestrated endothelium, gel-like basement membrane, and my podocytes of the Bowman's capsule. Each layer will be preventing something to pass into the filtrate. The first thing is going to be your blood cells. And why the blood cells are not going to be filtered? Because they are larger than the fenestrations of the endothelium. Next thing is going to be your plasma proteins. And the plasma proteins are going to be negatively charged. Like what's going to be negatively charged in the filtration membrane is going to be your gel-like basement membrane. Gel-like basement membrane is negatively charged, your plasma proteins are negatively charged, so that you're going to have a repulsion between the gel-like basement membrane and your plasma proteins. A third thing is going to be the macromolecules. And the macromolecules here will fail to get filtered. Why? Because they are larger than the filtration slits you do have between the feet of the podocytes. So you're going to keep blood cells, plasma proteins, and the macromolecules. You see on here, this is a section that shows the filtration membrane. So you see, those are the pores of the fenestrated endothelial cells. And then to the outside of the fenestrated endothelium, we have the cells with feet. What do we call the cells with feet? Those are my podocytes. And the podocytes are again the cells of your Bowman's capsule. So you see on here, those tiny little spaces between the feet of my podocytes, those are what we're going to call the filtration slits. What would you be preventing from passing here from your blood to the filtrate through the filtration slits? Those are my macromolecules. Questions? Moving on to the proximal convoluted tubules. The proximal convoluted tubules is the first set of tubules after we get out of the Bowman's capsule. And those cells, what did we mention about those tubules? They are responsible to do what? Can you remind me? To allow reabsorption. So, if you are getting paid, so somebody didn't give you a check, when would you deposit the check in your account? Today or after a month?
Today.
Alright. What do you think? So if you got a check today, would you deposit it today or after a few days or after a month?
If I need it, I might.
And if you do have to pay a bill, alright, you just received the bill today, and the due date is after 1 month. When would you pay this bill? Today or after a month? Just before the due date?
Realistically?
Just after, just before the due date. Yeah, this is what happens with most of us. Alright, so if you are getting something, you get it now. If you are paying something, you pay it as late as possible. Alright? Alright, this is what happens in the kidney.
So when you get paid, you are reabsorbing. You're getting all your stuff back. You do it now. This will be taking place in the proximal convoluted tubules. And we'll take everything back now. All the sugars, all the proteins, everything. I want everything now. But if I'm releasing, if I'm secreting something out, if I'm releasing something out, I will do it later. Alright, so this takes place in my distal convoluted tubules. So you see on here, when we check the cells of the proximal convoluted tubules, I will see that they have lots of microvilli. They have lots of mitochondria. I need to get everything back. So remember, microvilli are those projections of the cell membrane that will increase the surface area for absorption. So I have lots of microvilli here in the proximal convoluted tubules to reabsorb as much as I can. Because remember, do you release 175 liters of urine per day? No, you don't. You need to reabsorb almost 99%. So in the proximal convoluted tubules, I will be mainly concerned with reabsorption. But if I want to perform a maximum reabsorption, do you think I will need to have those columnar cells or to have cells which will provide me with a minimal resistance? What do you think? If I want to allow free water reabsorption, all the water to get back, I will need a high resistance or a minimal resistance? Minimal resistance. That's what we're going to have in the loop of Henle. So you see on here, if we didn't rely on the loop of Henle, so what was the function of the loop of Henle and the vasorector juxtamedullary nephrons is to form my concentrated urine. I want maximum water reabsorption. So if I'm using those long loops of Henle, do you think I will allow maximum reabsorption by having a high resistance or a minimal resistance? What do you think? Minimal resistance. And what's going to be providing me with a minimal resistance? One row of flat cells or one row of cuboidal cells? Which is going to be providing you with minimal resistance? What do you think? Flat cells. One row of flat cells. So that's why it makes perfect sense that the loop of Henle is going to be formed partly by squamous epithelium. One row of flat cells, simple squamous epithelium. This will form my thin segment of the descending limb. I am reabsorbing back. I want the maximum reabsorption if I'm using my loop of Henle to form as a concentrated urine. I want free water reabsorption. So what kind of epithelium is going to be lining again my descending limb?
Simple squamous.
Thin segment of my loop of Henle, this will be my simple squamous epithelium. And as I'm going up, so this limb on here is going to be my ascending limb. I will start to become more cuboidal and columnar as I get closer to my distal convoluted tubules. So in the distal convoluted tubules, this is the time where you're going to be paying. So what you want to get rid of, any toxins that you failed to filter. So if I fail to filter some of the uric acid, would you like to keep it forever?
No.
So what you're going to need to do, you need to actively secrete it, get rid of it, actively. So you don't rely on the filtration here. You will need to actively throw it in the urine. So the part of the nephron where you're going to be releasing here, this will be your distal convoluted tubules. So I am mainly concerned with secretion, then reabsorption. And this is why I will have fewer microvilli, because microvilli are mainly for reabsorption. So what I can see on here, the proximal convoluted tubule cells are having dense microvilli compared to my distal convoluted tubules, because they are not that concerned with the reabsorption
Would I have dense microvilli like I do have in the proximal convoluted tubules?
No.
No.
No. So we have less microvilli. Microvilli are responsible for you to get more back. So you see on here, in the distal convoluted tubule, you have less microvilli. So which one is going to be responsible for the reabsorption? Your proximal convoluted or your distal convoluted? So proximal convoluted, reabsorption, reabsorption. You're getting paid, right? Proximal. Which one is going to be responsible for secretion? Proximal convoluted
Distal.
tubules. Distal convoluted tubules. All right. So very important to keep in mind that both of them are going to be performing reabsorption, and both of them are going to be responsible for secretion. But I have one which is mainly concerned with reabsorption, and one is mainly concerned with secretion. So again, which one is going to be responsible for reabsorption? Proximal convoluted? Distal convoluted? Yes. So both of them will be performing reabsorption. Which one is going to be performing secretion? Proximal? Yes. Distal? Yes. So both of them are going to be responsible for secretion, but on different levels. Who is mainly concerned with reabsorption? Proximal. Who's mainly concerned with secretion is going to be
Distal.
All right, you see the difference? So on the test, whenever we ask you which one is going to be responsible for secretion, which one is responsible for reabsorption, keep in mind that both proximal and distal are going to be performing both reabsorption and secretion. But reabsorption will be mainly taking place in my proximal, and secretion is going to be mainly taking place in my distal convoluted tubules. All right? Moving on to the last part of my nephron, which is actually collecting the urine from those nephrons. After you perform your modification, you did filters of blood, you get your filtrate in the bolus capsule, you're going to be modifying the concentration of the filtrate now. So you get whatever you want back by reabsorption. You throw whatever you don't need out by secretion. All right? So what I will need to do after that, I will just need to collect all this urine that will be produced per each nephron to be conducted to my minor calyces, to major calyces, to the renal pelvis, and then from the renal pelvis out in the urine. So who will collect here? What are the ducts that will be collecting the urine from the nephron? Those are my collecting ducts. So collecting ducts, what's going to be the function? They are collecting the urine from the nephrons. And where will they travel? They are traveling, you see those lines on here? Those lines passing into what structure? Did we call this triangular shaped structure
Renal
that will be forming my renal medulla? What did we call those structures on here? Renal pyramids. So you see on here, what are the lines inside the renal pyramids? Those are my collecting ducts. So you're going to be forming the urine in the nephrons located mainly in the cortex.
Okay.
And then you're going to be collecting this urine out of the cortex into the medulla to travel through the collecting ducts traveling in my renal pyramids. And then from the tip of the pyramid, you're going to be conducting this urine out in the renal papilla, through the renal papilla, to the minor calyces, to the major calyces, renal pelvis, ureter, urinary bladder, urethra, to the outside. All right? Questions? So, is there any difference between the filtrates that I form here in the bolus capsule and the urine I'm getting out? Is there any difference between both of them? What do you think?
Yes.
Yes. Urine is representing less than 1% of the filtrate. What is the filtrate? Filtrate is simply everything
But blood.
without those three. without blood cells, without plasma proteins, and without macromolecules. Or in other words, plasma without proteins. So what is the filtrate again? This is plasma without proteins. And what is the urine? Urine is less than 1% of the filtrate. You're going to be reabsorbing more than 99% of the filtrate back into your blood.
Before it comes here.
Remember, you're not producing 175 liters. What's going to happen if I was releasing the filtrate as urine? I would remain for the rest of my life.
You would be there and you would never leave the bathroom.
Alright? So try to imagine 175 liters. So you need to be drinking all the time. And you're going to be releasing urine out all the time. This won't happen. You are, thanks to the reabsorption that takes place in my
And
what
your
organ?
proximal, convol, something.
proximal and distal, but mainly in my
Convoluted tube.
Convoluted
proximal
tubules.
convoluted tubules.
Convoluted.
Convoluted.
I hate that word.
I know.
Alright?
I hate that word.
It just doesn't sound
It's
right.
so hard.
It's so convoluted.
So the blood in the urine? Blood in the urine, yes, but this is not physiological. Not physiological. This might be pathological. It might have a UTI, urinary tract infection. So I've got an infection in the ureter, for example, or an infection in the urinary bladder or the urethra. It causes irritation, inflammation of the mucosa, which might cause bleeding.
Yeah,
So on the pathway, so I will see blood in the urine. Yes, I might have kidney problem. And the kidney problems are much more dangerous in this case. So if I've got a problem in my filtration membrane, like nephrotic syndrome or nephrotic syndrome, this disturbance in the filtration membrane, I am healing the filtration membrane by fibrosis. And if I've got destruction of the filtration membrane, I will lose its characteristics. So some blood cells will be able to travel. I will be able to find protein out in the urine. I will be releasing large amounts of water, unconcentrated. So I will lose the characteristics of the filtration membrane in case of pathology of the kidney. All right? So if I fail to filter the blood by a certain amount, as we're going to see later on next class, this will be what we consider chronic renal disease, which will progress to a renal failure if I'm not able to perform enough filtration because of the destruction of the filtration membrane. All right, but normally, do I see blood cells in the urine?
No.
It doesn't have. Blood in the urine doesn't have to be a kidney problem. It might be a urinary tract problem. All right?
Or intestinal.
Might be cancers anywhere in the urinary tract or kidney. Might be problems in the filtration membrane on here. Might be infections anywhere in the kidney or down in the urinary tract. And each one has its own characteristics, and you need to check the urine analysis to find out whether it's an infection, whether it's bleeding, whether it's something wrong with the kidney itself. And we can differentiate according to the reason, we can differentiate the different causes here. If, for example, I've got a problem in the filtration, so the blood cells are going to be packed in my kidney tubules, and we can see under the microscope in the urine that the blood cells are forming custs that are taking the shape here of the kidney tubule. So whenever you look under the microscope to the urine, you will find custs of red blood cells like this, tubes. They are taking the shape of the kidney tubules. But if I did have bleeding down in the urine, would I have custs? No, because the bleeding did not pass, those red blood cells did not pass into my kidney tubule, so I don't form custs. So this is one thing that will tell you whether you've got a kidney renal problem or post-renal cause of
of hematuria. So hematuria is blood is here. All right. So first step of urine formation, as we mentioned, this would be the filtration. And the filtration here is going to be by pushing the fluids out from the glomerulus, from the glomerular capillaries into the Bowman's capsule. And then next step in the urine formation is to get back this fluid. And this is what we call again my reabsorption. And this is taking place in my tubules. So we're going to call it my tubular reabsorption. And if you still got things that you want to get rid of, I still got things that I want to get rid of, well, I keep them by tubular
Secretion.
So 3 steps here of the urine formation. Again, those are my filtration, reabsorption, and
secretion.
All right, so what are the different pressures that will affect my filtration, my glomerular filtration? And this is my GFR. GFR is a glomerular filtration rate. This is the rate by which you're going to be performing the filtration. You're allowing fluid to pass from your vessel to your Bowman's capsule. This is my GFR. Again, what is the GFR? It's 120 milliliters per minute. So what are the effective pressures that will be allowing you to push the fluid from the vessel into the Bowman's capsule, into my kidney tube? What do you think? First, you need to differentiate between 2 pressures. One is called the hydrostatic pressure, and one is my osmotic pressure. Hydrostatic pressure is a pressure that pushes the fluid. So if I am pushing fluid, the force by which the fluid is going to be moving, this is called hydrostatic pressure. If I have a difference in the solid concentration, so water loves to move from high to low or from low solid to high solid. Can you remind me?
From low to high.
From low to high by osmosis. So this movement is due to what pressure? A suction pressure created by the side with higher solids. So you see on here, if I have lots of water on one side and few water on the other side, water loves to travel from high pressure of water to low pressure of water. So if I squeeze this bottle, I have fluid inside. I'm creating high pressure inside. So what's going to happen? The water, the fluid will be moving from high pressure inside to low pressure outside. So this is a movement of the water itself. This is a hydrostatic. Hydro is water, and static is stability of the water. So are we done? Are we done? Still have 10 minutes. All right? Still have 10 minutes. All right? So, I am moving water, and this water movement will create a force. And this force is my hydrostatic pressure.
Okay.
It's a pushing force. And what determines the hydrostatic pressure is your arterial blood pressure. The presence of a fluid that moves. And what determines the fluid in the pressure of the fluid that moves in your vessels? This is your blood pressure. Do you have on the other side any water, any fluid on the other side in your bolus capsule? So yes, I have fluid on here. What is the fluid in my blood vessels? Blood. And what did we call the blood pressure? The blood pressure.
Yeah.
That's a trick question.
On the other side of the membrane, what is the fluid that we do have in here? Do we have fluid on the other side? Yes or no?
Yes.
Yeah, and we call it
Filtrate.
filtrate. And if I have a fluid, it has a weight. And if it has a weight, it applies
Pressure.
pressure. Is it a pushing pressure or a suction pressure?
Pushing.
Pushing pressure. So you've got one pushing pressure from the blood vessel and another pushing pressure but in the opposite direction from the bolus capsule. So here I have fluid, here I have fluid, each one has a weight, each one applies a pressure. But both of them are opposing each other. It's a pushing force. Those are my hydrostatic pressure. So we're going to call the hydrostatic pressure from my glomerulus. This is my glomerular hydrostatic pressure. And we're going to call the hydrostatic pressure of my capsule. This is my capsular hydrostatic pressure. So again, whenever you have fluid, this fluid has a weight and it applies a pressure. And the pressure applied by the weight of the fluid, this is what we call again hydrostatic pressure. Which side has more solids, do you think?
The blood pressure.
Your blood or your filtrate?
Blood.
Filtrate.
So you see on here, you have more cells, you have more proteins, you have more macromolecules that you did not allow to get filtered. So all this means you have much more solids on which side? Your blood or your bolus capsule?
It's the blood.
Your blood. So in my blood I have higher solids.
So you have a higher.
So I have suction pressure. I am pulling water from low solid to high solid. This is what we call my osmotic pressure. It's a suction pressure. So you get two hydrostatic pressures and one suction pressure, one effective suction pressure. We don't have much suction pressure from the other side unless a person has diabetes. But normally I have two pushing pressures, two hydrostatic pressures, one in my blood, one in my capsule. They are opposing each other. One suction pressure that I have in my blood. This is my glomerular osmotic or colloid pressure. So again, three effective pressures here that will determine my filtration. So you've got, this is my blood, again, this is my blood in here, this is my tubule. I have one pushing pressure from inside of my glomerular capillaries. This is called my glomerular hydrostatic pressure. And that's why I need this pressure to be maintained. That's why I did need to have enough tissue perfusion. Because the tissue perfusion, your ability to get blood pushed to the inside of the kidney, this is what creates the glomerular hydrostatic pressure. You push out. And then you have filtrate on the other side that pushes on the opposite direction. So you have one pressure that pushes out. This is a glomerular hydrostatic pressure. And it's going to be pushing by a pressure of 55 millimeter mercury. And on the other side, I have a filtrate that pushes back. This is my capsular hydrostatic pressure, and this is of 15 millimeter mercury. So those are two pushing forces. I am pushing here from the blood vessel the fluid to travel to the bolus capsule by a pressure of 55.
And the filtrate that will be forming, this will create a wave, will apply a pressure of 15 millimeter mercury that pushes in the opposite direction. And again, remind me please, which side has more solids, your blood or your filtrate?
Blood.
Your blood. And if I have more solids in my blood, what's going to happen? You are creating an osmotic pressure, a suction pressure. You're pulling water to move back to your blood. And this will be about 30 millimeter mercury. So what is the net filtration pressure? If I'm pushing by 55, the other side is pushing by 15, and I am pulling by 30 millimeter mercury. So again, we have how many pressures? Three. One that pushes the fluid from your vessel to your Bowman's capsule. This is equal to
55.
And one will be opposing, pushing in the opposite direction by a pressure of 15. So subtract 55 minus 15.
40.
55 minus 15 is
40.
40 millimeter mercury. And then I am pulling in the opposite direction. So I have 40 that pushes from the blood to the Bowman's capsule. And then I have a suction pressure of 30 millimeter mercury. So I have now two opposing each other. One pushes out by 40 millimeter mercury, and one pulls back by 30 millimeter mercury. So what's going to be the difference in between the two pressures? 10. So I will end up pushing out by 10 millimeter mercury. This is my effective net filtration pressure. So if I told you you're going to be pushing this chair against me, so if I'm pushing by myself, I'm pushing at a pressure of 55, no opposing pressure. If you are creating an opposing pressure, can you push against me? But just let me push it a little. Yeah. So do I push at the same pressure?
No.
Do I move the fluid at the same speed? No. I will be slowed down. I will be losing part of the pressure. So the pressure by which I will be moving this fluid out is the difference between our two pressures. If I'm pushing by 55 and you're pushing by 45, so the movement that will be taking place is going to be under the effect of 10 millimeter mercury. That's it. This is my effective pressure that will allow the filtration to take place. All right? Thank you. Questions? So again, what do we call the pressure that will be created, the pushing pressure that will be created because of the presence of fluids? Hydrostatic pressure. What pressure would you create, a suction pressure, in the presence of a side with higher solid content? Osmotic pressure. This is a suction pressure. Questions? Yes.
Is it always that way? Those numbers? What do you overhydrate?
Overhydrate, you're gonna just remove all this water to the outside. You will not recollect. And we're gonna see which water are we collecting back and which water we will not collect. If I have overhydration, I did drink more water than what I need. We'll see what's going to happen on the brain level and what hormone you're going to be releasing, but this will be next class.
Hyponatremia or something like that?
What's that?
Hyponatremia?
Hyponatremia, so this will be hyponatremia. I have a decrease in my sodium in the blood. And this will be something pathological, which shouldn't take place unless I'm not filtering pure water out. Because if I'm drinking lots of water, I should be filtering just pure water without being accompanied with sodium. Alright, and we're gonna see how this will take place next time under the effect of the absence of ADH.
Alright, so please put a red circle on your name from last time. If you don't have your name on here, add it to the, just do the circle around your name.
I'll worry about the cheese later.
Good? You ready? Ready for this test? Why not?
I look at it this way, all we learn right now.
This supposed to be last week's review.
You know, I think that's program.
You put that on YouTube because that's a lot of still on
I got
Small ones that we don't even see.
I'm not even sure. I think I had the first two classes. I don't have everything else. I need to start labeling I keep it, at least I'm within the same, when I'm in the system.
appreciate that, man. It's hard enough.
I do it anyway. I might as well let everybody else down.
Yes, we can go over everything and study while we're testing ourselves.
Sure.
It's fine, you can turn it. Shall we go to the next one?
I am. I am free. I had a difficult time navigating. It's frustrating. Because you get right where you are and then it goes boom, zooms out. You're like, yes. There's a lot of it really
I was like, yeah, I'm not trying to be all the way over here, and then you're like, nah, I am right here. I was like, oh. Especially because I